Okay, well, thanks very much. Thanks for the introduction. In particular, thanks for the invitation to Dr. Winter and the group from the IAS. It's been a pleasure to be here for the past couple of days. I've listened to some excellent talks, and we have some other sessions planned tomorrow. And then I'm looking forward to Friday to meet some students, which will be a lot of fun. Okay. So this is the outline of my talk. I'm going to give a very brief review of respiratory physiology. Short. And then in trying to frame my talk to come here, I thought rather than show up and have all the answers, I thought I'd show up and ask questions. And so I've titled my talk 2 Unresolved Questions. So the first is, does the respiratory system respond to regular exercise and physical training in a positive manner? And I'll give two examples to show you that, well, maybe not. Chronic exercise training doesn't really do much to the pulmonary system in a human in a positive way. Still a bit open for debate. We'll come to that. The other question I'd like to address is, are there sex-based differences in the respiratory physiology of exercise? This has been something we've been working on for the last 10 years or so. And I'll again give you 2 examples to show you that, yeah, there probably are, and we're still working our way through what they may or may not necessarily mean. And that's open for discussion, hopefully, at the end. So, exercise physiology 101. The ability to locomote is dependent upon these organ systems. So lung, heart, skeletal muscle for generating locomotion, muscular contraction, ATP turnover. I'm not going to go through all this. This is a unitless graph where I've plotted all of the primary variables associated with each of those organ systems. On the bottom is rest to maximal exercise. So if I stick you on a treadmill and I keep turning it up and up until the treadmill finally wins, that's maximum. And so what I draw your attention to are 3 points. The first is oxygen uptake, the ability to take in and utilize oxygen at the level of the muscle for locomotion, ATP turnover. That goes up a lot. The other is cardiac output, the amount of blood pumped by the heart. So those of you that have a water bottle in front of you, but it's about 1 liter, and some elite athletes, you'll see a cardiac output of upwards of 40 liters a minute, which is remarkable. 40 liters a minute of blood circulating. And then the respiratory system shown here, the amount of oxygen in blood. So the partial pressure of oxygen in arterial blood. That's a flat line, despite a 20-fold increase in all these other organ systems. So how would you interpret that? Well, the lung does its job. So I had a student once tell me what that meant when I told him I studied exercise and pulmonary physiology. Air goes in, air goes out. What's the big deal? It's a flat line. So hopefully I'll illustrate there's a little bit more to that. This is a famous slide within my field. Dr. Dempsey gave this in 1986, long before word counts and page charges and journals. It's a lengthy manifesto, really a State of the Union address of respiratory physiology. And it served as a blueprint for many of us in the ensuing years, provocatively titled, "Is the Lung Built for Exercise?" So the idea here is that organ systems are plastic, and they will change in response to overload, training, physical activity, but the lung probably doesn't. So on the left-hand side is the relatively untrained person with a maximal oxygen uptake of 40. Healthy, but untrained. Where's the hierarchy in terms of organ systems that's limiting that person? Well, it's not the lung. It's probably at the level of the heart or skeletal muscle. Right? The ability to deliver oxygen to that muscle or the ability of the muscle to use it. Let's take that person and put them on the Bill Sheel fitness improvement plan, and I get them to a VO2 max of 75 mils per kg. So an elite athlete. We've had a reordering or a restructuring of those organ systems that's shown here, where if the lung responds without changing, and all the other organ systems do, those changes may surpass the ability of the healthy lung to oxygenate blood. What's the evidence for that? So that came from this paper. I'll just draw your attention to a couple of points. VO2 max, so their ability to take in and utilize oxygen at rest is, it's about 4-5 liters a minute, 72 mils per kg. These are fast people. These are sub 4-minute milers. Look at their arterial partial pressure of oxygen. I showed you on that initial graph, it was a straight line. It's not a straight line. It's downwards of 75, and in some of these people, it would drop down to 60. If you took a healthy young person and you put them in the hospital and said, take an arc line, draw blood, that would get them a chest X-ray. Something's going on here. The other feature of this is the widening of what the partial pressure of gas in the lung to that in the blood. You and I sitting here at rest, it should be about 3-4 millimeters of mercury. 33 millimeters of mercury. That's highly inefficient gas exchange. So there's an abnormality somewhere. Up for another discussion, but evidence that the lung probably isn't changing in response to chronic exercise training. This is really a bit of a paradox. And I like this slide, and it fits with the way that I've framed this. The way that he ended his paper was the following, and I like it. I use it a lot. On the one hand, the idea is especially appealing in a philosophical sense because of its conceptual tidiness and confirmation that no organ system has limitless capacity. On the other hand, given our long list of untested speculations, we could use a bit more data. And I would argue that's probably still true. Okay, now the other example I wanted to go through was aging. I thought of doing this, but I won't. Let's imagine, because I don't want to turn this into an aerosolizing event, but let's just imagine that you're doing pulmonary function, that you were to hold your nose and take a big breath in and a big breath out as hard and fast as you can, and then another big breath in, okay? Pulmonary function, easy. That's the outer loop that's shown there. That defines the ability of the lungs, airways, respiratory muscles for generating changes in pressure and flow. That's your capacity. That's what you've got, okay? Shown within those loops are exercise loops. So the smallest one is you sitting there at rest. Breathe in, breathe out. No, so x-axis is volume, how much air is in, coming out. Y-axis is flow, how fast are you doing it, okay? So if this is the resting loop, now you're on a bike or a treadmill and I make it go faster, what do? Depth of your breath gets bigger and the flow rate gets higher. Okay. Keep turning the bike up until the bike wins. That's the maximum loop. What you'll notice here is that those exercising flow volume loops are well within the capacity of your maximum loop. You have lots of room to still increase flow and or volume. Contrast that with the aging person. With aging, there's a number of structural changes that occur. And shown here is this is a very fit, healthy, older person. Their VO2 max values are the same as the young person. So the first thing to notice is that the peak flow is lower. The volumes are lower, right? So the capacity that you have is smaller, the pie is smaller. And what fraction of the pie are they using during exercise? It's encroaching upon that. So we call that expiratory flow limitation, where the expire arm intersects with what's going on there. That leads to, in some instances, dynamic hyperinflation, puts the respiratory muscles in a mechanically disadvantaged position. Well, what happens if you train these people? Is that just a function that this person is older? Well, that's been addressed here. Hopefully you can see that in one of the better longitudinal studies, where they had the same people do very, very detailed lab measurements over a period of 6 years. These people continue to train. They are upwards of 150% predicted aerobic capacity. And yet, despite the chronic years of training, they experienced a reduction in oxygen uptake, a reduction in maximal minute ventilation, and the degree of tidal volume intersection increased, regardless of being extremely fit. So to my way of thinking, that's some evidence that the lung's not changing in response to exercise training in a positive manner. However, I'm not an epidemiologist. I think you are. This is the fly in the ointment. 25-year follow-up study in a rural Finnish group. Self-reported measures of physical activity, very general spirometry. You give them a little thing to blow on and you take it home. people that are reporting to be physically active have less of a decline in lung function. And that also holds true in the people that smoked. The argument there becomes that exercise in and of itself may be an anti-inflammation mediator that's preventing some of these changes. Now, there's a couple caveats. Self-report. Lung function is only at rest. I have no idea what they're doing with exercise. I don't know what the mechanisms are. It's not addressed in this type of work. So as an experimentalist, it's not overly satisfying, but it's there. And I think it needs to be pursued. And so to shift gears to the other question I wanted to ask, and I thought about how to best introduce this, sex-based differences in physiology. And I thought I'd just share this photo with you. Some of you, I see Bill nodding, knows what this is. This is Catherine Schweitzer. She's the first person to enter as a numbered entrant into the Boston Marathon, because at that time, women were not allowed to run. Maybe during question period, we can talk about that. What you're seeing is the race director, upon hearing there was a woman in his race, got in a truck, drove out onto the course to try and physically remove her from the course. This is not that long ago. And I'll add that ensuing from this, many of the classic human physiology studies dealing with the pulmonary physiology of exercise don't include people that look like her. Almost exclusively done on men. That's starting to change, and so that's the premise for the question I asked. And so I wanted to introduce you to a couple of measures, experimental type things that we do. So shown on the left, we want to measure the work of breathing. So how do you do that? Well, it gets a little bit invasive. Where we place a balloon into the esophagus, put another one into the stomach, and then we can record EMG across the primary muscle of breathing, diaphragm. In this case, I'll just show you why we do that. That's shown here in the middle. This is a scan of a human, and shown in red is the esophagus. And the esophagus is a fairly flaccid structure, right? So if you insert a balloon in and it sits in the lower third of the esophagus, and you make an inspiration, that generates a negative pressure that's transmitted to that little balloon, which I can connect to a pressure transducer outside of the human, and I can calculate work if I know pressure, volume, flow. Just if you haven't seen this, I thought I'd show this, and there's a reason why we don't have sample sizes of 1,000, because each study requires doing something like this where you have to do invasive things. There's a little bit of lidocaine in there. These are graduate students. I've had it done lots. You can sleep with them. You can do all kinds of things. And then she's going to retract the guide wire, which is less fun. A little bit of a gag reflex there. There we go. Okay. Yeah. And just so you know, he defended his PhD last week. So the other method I wanted to show you to try and address some of these sex-based questions. So that's how we calculate the work of breathing. We're interested in the relationship between the work of breathing and the anatomy of the airways. So that's a tough nut to crack. So shown here is my colleague, Dr. Lamb. And then when you have crazy ideas, everybody says, that's great, you go first. So I'm the participant here. So this is in the bronchoscopy suite. And the way this works is, so there's conscious sedation with fentanyl. They insert the bronchoscope. Out of the bronchoscope, there's a little biopsy port. Comes this fiber optic cable that can be advanced to about 1 millimeter. So about the 8th generation or so. And then it's pulled back on a fixed rate here. And it spins as it comes back. You're able to thread that through different regions of the lung. It looks like that. And then when you pull it out, this is the image that you get. The top shows you the sheath in color. And then you can see an airway. There's a little bit of alveolar multiplication at the bottom. You can kind of see. And then it takes the airway kind of like a paper towel roll, cuts it in half, lays it flat. And it looks like this. Each one of those indentations is a branching point. And so it's moving from distal to proximal, and you can get a sense of the change in airway diameter. This is proximal, distal, pardon me, to proximal. So it's getting bigger as the camera is being pulled out. So these are real human values. Let's do that. And you can get these kinds of images where you can get a measure of the lumen, right? You can also get a measure of the airway wall, which for those of you that are interested in pollutant exposures or tobacco exposure, that gives you a sense of remodeling. It's almost like a visual biopsy. And so with that, you can calculate radius of that vessel, and you can do it along the airway tree. And we were able to do that pretty successfully all the way down to the 8th generation or so. And so when we do that and we try to make comparisons between men and women, there's this idea that if you take a relatively tall female and a relatively short male, you match them for lung size, the airways are still different. They're still more narrow in the female. And that's true. We've shown that in a half a dozen studies now, and some other people have done it using different methodology. But what we were interested in is, does that have any bearing on function? And it does. So here shown on the top is the work of breathing. I showed you the method with the balloon. We calculate that, joules per minute, as a function of minute ventilation. But then you can take the total work of breathing and you can partition it out. There's different ways of doing this. You can partition it out into the resistive work of breathing or the viscoelastic. So you have to move stuff when you breathe, right? But the resistive work of breathing through the airways. So you would predict with a narrower airway, you would have a higher resistive work of breathing owing to this equation here, which is the resistance to flow, radius to the 4th power, which I suspect some of you know. And so it's true. We've seen this. Other people have shown this. There's this worry about a crisis of reproducibility in science. It makes me really happy that other people have started to show this as well. So it's not just us. Okay, so if you think that the female diaphragm may be more, the work of breathing and the resistive work of breathing may be higher in a female, particularly in these elite athletes, does the primary muscle of respiration, the diaphragm, might that fatigue differently between men and women? And so you can measure that. You place the balloons back in again, you stimulate the phrenic nerves. It's kind of like getting hit with a shovel lightly. And it makes your diaphragm contract, and you're able to measure the pressure generating capacity of that muscle. And I've taken a bit of license here. These are out of order, but it's not true. The female diaphragm is more resistant to fatigue, which has been fascinating. Fascinating. I'm going to show you what I think that might mean. And other people have started to show this too. So we wanted to take exercise out of the equation because exercise complicates things. So in this apparatus, it's an isolated inspiratory task where we basically beat up the diaphragm. They have to suck through this apparatus, lift a weight to generate airflow, and the diaphragm fatigues. The person who did that study is actually sitting in the back. He's now got a new fancy faculty position at Birmingham, so glad you're here. Thanks for coming. So this is part of his doctoral work. And if you have men and women, healthy, perform these tasks to the point of fatigue, it's like doing an arm exercise, right? Imagine doing this. Squeeze, relax. Squeeze, relax. You're occluding blood flow. What's the response to that occlusion of blood flow? That's an error signal. You change blood pressure. In response to the same type of contraction, but this time with the diaphragm, the female blood pressure response is less. So is that something that's happening within the muscle itself? Is the signal different? Is it a relative or absolute workload? So we're trying to unpack some of those relationships, but we've shown that in a number of different ways. And most recently, this is Mick Leahy's work, who defended his doctoral dissertation the other day. He cleverly said, well, there's some suggestion that progesterone modifies fatigue responses and muscle metabolism, as well as blood pressure responsiveness. So he tested young men and women. The women were in the mid-follicular phase when progesterone should be at its highest. And he tested postmenopausal women, where that influence was absent. So this graph is showing you same type of task to fatigue. Young men, Young women shown in the open bars. Female response blunted. But the older female, when there's an absence of progesterone in the system, responds in the same way as the older male. So it's a clue that the progesterone may be at least in part mediating this blood pressure response. Okay. So healthy aging is associated with higher blood pressure in males and females. The effects of sex is present in the younger, but not in the older group. Young female, of course, they were taking no hormonal contraceptives. I think that's an important point to make. Self-reported mid-luteal phase with elevated progesterone, and the older women were in menopause. So the blood pressure response, at least to our interpretation, seems to relate to possibly the presence and or absence of circulating ovarian hormones. So the questions. Does respiratory system respond to regular exercise training? Well, if I try to provide a couple of answers, I think there's a need for more in-depth, long-term investigations, not cross-sectional ones. Effects of health, different environmental conditions, as well as chronic disease. What do you do with people that are in a pulmonary rehab program? Are you hurting them? Is it beneficial? Question 2, are there sex differences in the respiratory physiology of exercise? I make this point purposely. There's a need for careful, because it's easy to do wrong, careful inclusion of sex and gender. Those are not the same thing. We can talk about that later if you want, but embedding those within scientific design a priori is important. And if there are sex differences, and I've highlighted a few that we think we're seeing, what do they mean? You see these in healthy young people. What happens in an older person who might have a chronic disease with age superimposed upon that? And I also think this worth underscoring. It's also important, not everything has to be different, that there might be similarities, and we should pursue those as well. And lastly, I do think there's a need to link experimental work, which is what I do, with those who are conducting epidemiology-based studies. I'm not sure how to crack that nut, but I think it's important. And considering social and environmental influences and perhaps epigenetic phenomena that may modify some of what's going on. With that, I'll thank you for your attention, the people that really do the work, and a handful of agencies that thought our questions were worth looking at. So thank you.